Hello, my name is Christy Krail Javier, and I will be presenting my Doctorate of Nursing Practice project, Alcohol and Breast Cancer, a New Approach to Prevention Policy. Breast cancer is the world's most prevalent cancer and is the second leading cause of cancer death in U.S. women. 1 in 8 American women will develop invasive breast cancer in their lifetime. While the 5-year survival rate has steadily increased, occurrence rates also continue to rise. So in other words, women are living longer with breast cancer, but more women are being diagnosed each year despite all of our mitigation efforts. But breast cancer is a largely preventable disease with many lifestyle risk factors implicated in its development, and most newly diagnosed cases have known modifiable risks. In fact, about 85% of cases occur in women who have no family history at all. Existing evidence suggests that up to 50% of cases may be preventable by adherence to healthy lifestyle practices, with the reduction of risk proportional to the degree of that adherence. Alcohol consumption is a well-established and leading modifiable risk factor for female breast cancer, of which only 30% of women are aware. It's estimated that 7 out of every 100 cases of breast cancer is attributable to alcohol, and the risk is confounded by other lifestyle and genetic factors. Confounding influences associated with various combinations of multiple risk factors have a cumulative impact on breast cancer risk, and together they reflect a woman's true risk profile. Studies on alcohol as a risk alone have been done on hundreds of thousands of women over the past 4 decades, with results that really should give pause to the standard approach to breast cancer risk assessment and prevention that's currently being employed today. So the purpose of this scholarly project is to assess the need for improved risk assessment and breast cancer prevention policy being used in the clinical setting by evaluating existing policy against best practices stated in the most current literature. Specific aims of the project are to determine standard breast cancer prevention policies and procedures being used in primary care and the office compliance with these policies. It's to evaluate those organizational policies and procedural standards for their quality, integrity, development, and alignment with the best and most current evidence. And then to identify areas in need of policy reform, and then to offer policy modifications in accordance to evaluation findings that align best with best evidence, and then ultimately to bring awareness to alcohol-mediated and lifestyle-driven breast cancers. So the methods included a 2-part data collection process. First, staff members of a small family practice were interviewed to determine their breast cancer prevention policy using a self-made data collection sheet. They were then asked specifically about their in-office approach to breast cancer risk assessment and prevention. Second, the appraisal of guidelines for research and evaluation 2 instrument, also known as the Agree To instrument, was used to evaluate those policies and the clinical practice guidelines found to be governing practice standards. So the Agree To instrument is the international gold standard for appraising the reporting quality of practice guidelines and the associated recommendations. Quality is defined as the adequate management of potential biases and the internal and external validity of the recommendations, as well as their practice feasibility. The Agree To instrument is a published, valid, and reliable evidence-based tool that's endorsed by numerous healthcare organizations. The Agree To instrument is comprised of 23 items that are arranged in 6 guideline quality domains: scope and purpose, stakeholder involvement, rigor of development, clarity of presentation, applicability, and editorial independence. And you can see here each of the 23 items that are organized within each of those 6 quality domains that we will be using to analyze the policy. Each item was scored on a 7-point scale, 1 indicating strongly disagree and 7 indicating strongly agree. Judgments were then made using the agree to assessment criteria and considerations specific to each quality item. So the assessment criteria identify explicit elements that reflect the operational definition of the item, and the more criteria met, the higher the score the guideline would receive on that item. So basically, there's a user's manual that guides the whole appraisal process by laying out a clear description of each item, along with instructions on how to find the information in the guidelines, and then how exactly to rate that information provided, and then additional questions to consider before actually judging the guideline. So it's a very controlled process. After each item was rated, each of the 6 quality domain scores were then calculated as a scaled percentage of the scores applied to each item within that domain. Therefore, each domain received an independent score based on the items relevant only to that domain. An overall quality rating was assigned to the guidelines based on the individual item quality and using that same 7-point scale. Then recommendations for use in clinical practice were suggested, and this concluded the appraisal. So the results. It was found that during well-woman visits and routine follow-ups, breast cancer prevention strategies are approached primarily by following recommendations within the American College of Obstetricians and Gynecologists Clinical Practice Guidelines for breast cancer risk assessment and screening in average risk women. There were no specific in-office policies, procedures, or internal documents that outlined an approach to breast cancer prevention as part of practice standards. Instead, I was just deferred to the ACOG guidelines. In-office screening for breast cancer risk was considered part of an intake form checklist that includes 2 questions. One question asks if women are doing self-breast exams regularly, and the other inquires about routine mammograms as recommended by national guidelines, if age appropriate. The only means of in-office identification of high-risk patients is the initial patient intake form that asks about family history and incorporates a genome. So, due to the lack of office policy, the guidelines analyzed using the agree-to instrument was the ACOG guidelines for risk assessment and screening, the guidelines seen here. And here's how the guidelines rated in each of the 6 domains based on their individual item scores. And this graph shows how each item within each domain rated. And here again is what each domain represents. So domain 1, pertaining to scope and purpose of the guidelines, ranked the highest, with the strongest level of agreement at 83%, while editorial independence, representing transparency of potential bias, ranked lowest. So domain 1, the scope and purpose, the main weakness within this domain was the inability to accurately describe the target population of average risk women because there's no standard method of evaluating risk. Domain 2, which pertains to stakeholder involvement, received a score of 61% agreement for several reasons. One being that members of the Practice Bulletin Committee were not listed and therefore cannot be scrutinized. Another is because of the disservice to patients as stakeholders. And this is due to the inadequate risk assessment based only on familial and genetic risks and exclusion of modifiable risks. So another problem is the lack of proper education regarding evidence-based lifestyle recommendations from the American Cancer Society and the World Cancer Research Fund. So depriving patients of this education makes it difficult for them to effectively share in that mutual decision-making, regardless of how much mutual participation is encouraged in the guidelines, and it was. So, domain 3. The agreed-to appraisal is largely centered around the 3rd quality domain, which is comprised of 8 items analyzing the guideline developmental process and it received a low agreement score of 48%. This is because the strength of the supporting evidence for the guidelines is questionable, and there's no clear description of methods used to formulate recommendations. Most importantly, it was found that the large body of evidence supporting the influence of lifestyle risks, including alcohol, on breast cancer development is excluded as evidence to inform the patient's overall risk assessment and prevention plan. So domain 4, clarity of presentation. The most significant finding here is the narrow scope of breast cancer prevention strategies and procedures offered in the guidelines. Risk reduction counseling based on the American Cancer Society and World Cancer Research Fund evidence-based risks are not part of patient education. Furthermore, screening options are limited to mammography. There's no screening recommendation for women at risk for alcohol-mediated breast cancer or those who have multiple lifestyle risks enabling a high-risk condition. These issues all seem to be due to the exclusion of pertinent evidence. Domain 5, applicability. Applicability of the guidelines received a 38% for all of the fundamental reasons previously discussed. But what stood out in this domain is that this is a detection-based rather than prevention-based policy. And even the guidelines for detection, which is mammography screening, aren't based in solid evidence. Yet, there is strong evidence for the need to screen for lifestyle-related risks, particularly alcohol drinking, to prevent occurrence. But this is not included in the guidelines. Oh, wait a second. I want to mention that mammography screening was not a focus of my project. So this was found inadvertently during my analysis. I found it to be significant because the guidelines are basically saying that they don't know for sure if screening at the recommended frequency or any frequency is beneficial because it's too hard to measure. But they do acknowledge that there are serious side effects such as overdiagnosis and overtreatment to consider. And this finding makes the current recommendations for mammography screening highly questionable, with an unknown risk to benefit ratio. And I thought this was important as far as the integrity of the guidelines as a whole. So I did want to talk about it. Okay. And then editorial independence, the last domain. This received the lowest score due to the lack of transparency surrounding mostly funding and the competing interest of the guideline developers. It was just not disclosed. So based on these findings, the ACOG guidelines were given an overall quality rating of 4 out of 7 possible points, and the guidelines are recommended for use in clinical practice with modifications. And these modifications are provided with a suggested approach to their implementation and all of the supporting evidence in the project paper. And then I'll review them very briefly in just a moment. As I analyzed this data, one of the first things I noticed is that there is a blind trust in the ACOG clinical practice guidelines. And this is likely the case with many national guidelines, but here the ACOG guidelines are being used unvetted as the sole policy to inform breast cancer prevention standards and procedures, and are basically taking the place of any local practice policy. And this is with practitioners trusting that these guidelines are consistent with the most accurate and current data. Oh, wait, again, sorry. An analysis of the data generated from the policy appraisal itself mainly reveals a substandard development process which has excluded a vast body of relevant supporting evidence pertaining to breast cancer prevention. As a result, clinical practice recommendations were found to be insufficient, mainly concerning the risk assessment process and the criteria for establishing a risk profile. The omission of substantial evidence seemed to have had a snowball effect on each of the quality domain scores, affecting the quality items differently, with the source of the problem really remaining the same. So overall, the clinical practice guidelines do not reflect current best evidence, and numerous areas within the guidelines are in need of reform, and that is at the highest level, the national level. The results of this study expose a multi-level systemic breakdown of evidence reporting that has a negative impact on breast cancer prevention opportunities in primary care. The exclusion of evidence-based lifestyle risks and the recommendations from the World Cancer Research Fund and American Cancer Society from the guidelines supporting evidence makes it impossible for practitioners to ascertain an accurate patient risk profile. And without knowing a patient's true risk, determined by the total impact of behavioral and non-behavioral insults, adequate recommendations for screening and prevention cannot be made. This is observed in the lack of screening recommendations for those at risk of alcohol-mediated and lifestyle-driven breast cancers, which we have learned are many. The exclusion of patient education related to lifestyle risks, such as alcohol, from prevention policy does a great disservice to patients and feeds the overemphasis of genetics and family history found within the guidelines. It also contributes to the confusion surrounding the concepts of detection versus prevention. Mammograms are a means of detecting disease that already exists and has been accumulating for years, possibly decades prior, whereas prevention involves altering one's lifestyle and habits that reduce the risk of ever developing disease in the first place. I have met many patients who believe that they are doing their due diligence by getting a yearly mammogram, but they continue to eat poorly, they lead sedentary lifestyles, they take hormone replacement therapies, or they drink alcohol daily without even thinking much about it. So it's the practitioner's responsibility to clarify these misconceptions that may be leading to these behaviors. Additionally, without proper education, patients cannot make fully informed decisions regarding their screening and prevention protocol. The questionable support for frequent mammography screening also highlights and substantiates the need for a reevaluation of this current one-size-fits-all breast cancer prevention policy focused mainly on detection. So this project has many implications for nursing practice, but they can mainly be observed in the modified policy recommendations. This is what I had mentioned earlier. These were the recommendations that I've made. The first is intended to inspire a truly comprehensive and standardized means of breast cancer risk assessment that can be done at the bedside in primary care. It would include the overall impact of patients' familial, reproductive, and breast health history, as well as the patient's dietary and lifestyle habits, alcohol intake, and environmental and hormonal exposures. Education that advises all women to control their intake and promotes adherence to the World Cancer Research Fund and American Cancer Society breast cancer prevention lifestyle recommendations should be embedded into the risk assessment process. So while we are assessing risk, we need to be educating patients. By incorporating screening and patient education for alcohol-mediated and lifestyle-driven cancers, it would bring awareness to the magnitude of influence these factors have on a patient's risk, and it's intended to inspire positive behavior modification consistent with risk reduction. Screening and prevention recommendations should reflect the patient's individual risk profile, and alternatives to mammography should be offered to eligible patients with a lower risk profile and those with lower risk profiles. Now, time constraints have been recognized as a barrier to implementation of these recommendations, which could place a new set of challenges on practitioners in addition to new educational requirements. So this is in fact acknowledged. So adoption of these new recommendations would require a simple, efficient process for implementation, which can be achieved through the use of an evidence-based, standardized risk assessment and educational tool. This idea of a tool has great implications for future research to develop a user-friendly instrument for practitioners. Other implications for future research includes the need for more appraisers, consensus regarding guideline quality and data dissemination for project realization and operationalization. The agreed-to process requires at least 2 appraisers to achieve consensus on the judgments, but due to time constraints, invitations to participate were declined to participate in the appraisal process. So consensus is really needed to strengthen the recommendations for guideline modification and to validate their applicability to ensure adoption into clinical practice, which is the ultimate goal here. And these are the references for my project. And I want to thank you all for listening, and I hope it was inspirational